Welcome back. Here we are in part 6, a little bit more about the advantages of classifying medications according to their mechanism of action. We had mentioned calcium channel blockers in the previous recording. So we have calcium channel blockers, and they block those calcium channels in the smooth and cardiac muscle. When they block them in the vascular smooth muscles, they dilate the vessels. With that dilation of the vessels, it then reduces the blood pressure. When they block calcium channels in the heart, they slow conduction, so they are also used to treat cardiac arrhythmias. So if we classified these medications based on their use, we would have to learn about them at least twice. But if we classify them based on their mechanism of action, we can learn about them once and then apply that knowledge to different uses or to different client needs. So in this case, we would have to look at calcium channel blockers and their antihypertensive effects. And then we would have to look at them again for their cardiac arrhythmia or dysrhythmia suppression effects. However, if we look at calcium channel blockers and see how they block the calcium channels in the smooth and cardiac muscle, we can then apply that mechanism of action and take it a little bit deeper to understand the greater effects versus just the singular, very specific effects. This is what you should be doing for each and every one of your classes of medications. Understanding the mechanism of action is of great importance. Once you understand that mechanism of action, you'll be able to apply that to multiple uses or multiple disease processes. Because not just one medication may only be used to treat a cardiac condition. A medication to treat a cardiac condition may also be used to treat a peripheral vascular condition. So in this course, like I mentioned, we're going to use a blend of classification by use and classification by mechanism of action. When we first look at a particular drug, we're going to take a look at its mechanism of action along with its use in relation to the body system that we're talking about. We will encounter the same drugs later, and we will refer you back to its mechanism of action and explain how that drug works in the new body system. So for example, furosemide. Furosemide will be spoken of quite early in this course, and it is used to treat fluid volume overload. It is a loop diuretic. Furosemide will also be talked about later in the course when we get to perfusion, when we speak about congestive heart failure, because typically with those patients, they have problems with perfusion, but they also have a problem with fluid and electrolyte imbalances as well. Some medications do have an off-label use. An off-label use is something that a medication can be used for, but the data is not there to support its use for that condition. It is also has not been researched for that condition, but perhaps there is some evidence somewhere that it may have some desirable effect or to treat the ailment or disease processes that it is being administered to treat. In regards to drug safety, there are several mechanisms for which drugs are deemed safe. As we mentioned before, the FDA and research companies go through a rigorous process for which they research and approve and develop these medications. There is no such thing as a completely safe medication. As we talked about before, these medications do have their side effects and they do have their adverse effects. But it is important to know that there are several mechanisms through which researchers, the FDA, healthcare organizations, physicians, nurse practitioners, and nurses can be safe when administering medications. In regards to controlled substances are those that have a potential to be abused. They are regulated by the DEA, not the FDA. Each prescriber has a DEA number that is on the prescription, and it must comply with the DEA regulations. These prescribers are regulated by each and every state. So it is important to keep track of the quantities of these substances and who receives them. This is especially important in now these days with the opioid crisis. Here you can see the categories of controlled substances. You have Schedule 1, Schedule 2, Schedule 3, Schedule 4, and Schedule 5. Schedule 1 drugs have no accepted medical use. There's a lack of accepted safety and high abuse potential. This would be heroin, marijuana, MDMA, or ecstasy. Your Schedule 2 drugs are drugs that are potentially at risk for patients to be abusing them. They are used medically, but they do have that high risk for abuse potential. This could be codeine, methadone, hydromorphone, also known as Dilaudid. Your Schedule 3 medications are drugs with less potential for abuse than Schedules 1 and 2, but they could lead to dependence. Schedule 4 are drugs with an accepted medical use in the US, but also some potential for abuse. And then Schedule 5, these are products containing moderate amounts of controlled substances. There may be restrictions on amounts sold. This could be cough suppressants or antidiarrheal medications. Here are just some additional safety mechanisms and actions. The rights of medication administration. So your main rights of medication administration: the right patient, the right dose, the right frequency, the right route, the right assessments, the right evaluation, the right to patient refusal. So those are all some of the rights of medication, making sure we check 3 times prior to administration. Abbreviations. Abbreviations can lead to errors in medication administration, so it is appropriate to have the correct abbreviation when abbreviating, or if there is the potential for the unknown, we should be simply writing the entire medication out, the entire name out. High alert medications, we will talk some more about those. And the prevention of medication errors, everyone has a role in that. Drug manufacturers, healthcare organizations, the nurse, healthcare providers, physicians, physician's assistants, nurse practitioners, and the patients and consumers also have a role in the prevention. I think education has a lot to do with that there. So a little look at lifespan considerations. Our most vulnerable populations are pediatrics and the elderly, and those with chronic conditions or multiple comorbidities. So with lifespan considerations in pediatrics, in regards to pharmacology, most commonly, a dosage for pediatrics is going to be based on weight. Some considerations to take into effect here are the decreased gastric emptying. So this medication may stay in the system longer in a pediatric patient because of that. An immature blood-brain barrier. So this would lead to an increase in the central nervous system effects of certain types of medication. Pediatrics typically have a decrease or immature, not fully functioning kidney and liver, and this could lead to a decrease in that metabolism and a decrease in the excretion of the medication. So what does this mean? So this means the medication stays in the body for a longer period of time. It means that the medication is going to have a longer lasting effect. So in regards to dosing, this may mean that the patient needs a decreased dose or a decrease in frequency of that dose. With your geriatric or your elderly population, a couple of things to consider here. Polypharmacy. Polypharmacy is the intake of multiple medications. So this could be because the patient has multiple comorbidities. They have multiple health issues for which they need to take medications. So here you have an increased risk for drug-drug interactions. You may have an increased risk of toxicity. You may have an increased risk of inability to adhere to the medications with all of these medications being taken at once. So going down a little bit to medication adherence, this could be because of polypharmacy, but it could also be because of a deterioration in mental status, a deterioration in their sensory capabilities, a deterioration in the dexterity, that comes with age, or it could also be economic or factors or social determinants of health types of factors here. In regards to the body and the pharmacokinetics related to your geriatric or elderly population, the absorption, distribution, metabolism, and excretion has the potential to be affected. You may have decreased absorption. You may have impaired distribution, altered metabolism, and impaired excretion. However, this is not to say that every patient greater than 65 or your elderly or geriatric patient is going to have a problem with the pharmacokinetics, with the metabolism, with the excretion, but it is a potential for that to occur. So because of this, we may also need to be evaluating the patient's responses to these medications, looking out for toxicity, looking out for renal impairment in order to potentially choose to decrease the dosage based on the BUN and creatinine or the patient's kidney function prior to administration. So these are important items to consider when you are working with your elderly patients and considering the medications that they are being administered and the management of those medications within their regimen. So here's a question. When caring for an elderly client with decreased kidney function, the nurse observes for which consequence resulting from slow drug excretion: a delayed drug onset, a delayed drug peak, an extended drug half-life, or a rapid drug plateau. So if we look at this question, the patient is elderly, they have decreased kidney function, then that leads to slow drug excretion. This is not really going to affect the onset or the peak. It is not going to cause the medication to have a rapid drug plateau. It is going to extend the drug half-life. We had spoken before about drug half-life. Drug half-life is the time that it takes for 50% of the drug to be excreted from the body. So if we have slow drug excretion due to decreased kidney function, medication is going to be staying in the body longer. So that is going to then prolong or extend the drug half-life. Here, the nurse gives a client an intramuscular dose of penicillin G for syphilis. What is the priority action for the nurse after giving the drug? Monitor the client for at least 30 minutes for any reaction. Massage the site with an alcohol prep to ensure even distribution of the drug. Teach the client the importance of not having sexual intercourse for at least a week. Ask the client if they are allergic to any medication. So here we have penicillin G. What is the priority for the nurse after giving the drug? Monitor the client for at least 30 minutes for any reaction. That seems appropriate. Massage the site with an alcohol prep to ensure even distribution. That is not appropriate. That is not proper administration technique for an intramuscular injection. Teach the client the importance of not having sexual intercourse for at least a week. That is not appropriate here. Ask the client if they are allergic to any medications. This should be done prior to administering the medication, not after. Monitor the client for at least 30 minutes for any reaction to the drug. This is an appropriate intervention. Penicillin has a high incidence of allergies, so we would want to monitor the patient in order to see or assess if they have any type of reaction to the administration of that medication. When administering an antibiotic via secondary IV line, or IV piggyback, into a primary solution of normal saline with 20 milliequivalents of potassium, the nurse checks the drug literature for drug compatibility before starting the antibiotic. The nurse does this to prevent which pharmacological consequence? A synergistic effect, a drug-drug reaction, a toxic effect, or an idiosyncratic effect? The correct answer here is drug-drug reaction. The reason why is we have administration of an antibiotic, which is being piggybacked into the primary solution that has potassium in it. So those two, if they combined, they have the potential to create a drug-drug reaction.